All right, we're going to go ahead and get started. So I wanted to welcome everybody to our monthly Miami Pediatric Neurosurgery Symposium. Today, I have the really honor of introducing Dr. Daniel Curry, who is the Director of Functional Neurosurgery and Epilepsy Surgery and the John S. Dunn Foundation Endowed Chair for Minimally Invasive Epilepsy Surgery, as well as Professor at Baylor College of Medicine. Today, he's going to give us a little bit of introduction, and we're going to speak further on MR-focused ultrasound for pediatric patients. And then Heather, why don't you let us know who the second speaker is?
Yep. And I'd like to introduce Travis Tierney, who will be speaking second. He's Professor of Brain Sciences at Imperial College London, and MR-focused ultrasound is really a passion of his, so I think it'll be exciting to hear his talk as well. And then we hope all of you will add your questions on the chat portion so that we can ask them at the end of both speakers and have a nice discussion today.
All right. Okay. Thank you. So go ahead.
Yeah, I'll go ahead and do an introduction. So I was asked by the group, and thank you very much for the invitation, and by Travis as well, to kind of give some context and some introduction to the concept of focused ultrasound in the pediatric population. But ironically, I'm giving it to the one place that has done it. So my main disclosure here is not that I'm a consultant for Medtronic. It says I haven't done this yet. We have got the device. We are finished the installation. I have done some training, but I have yet to get my anxious hands on a focused ultrasound machine to apply it to the deep minimally invasive targets that I've focused my career on. So a lot of this introduction is really putting it in the context of where it can go from my point of view. So I don't need to tell this group much about it in the sense that, it's a minimally invasive incisionless surgical intervention that thermally ablates small targets deep in the brain. And I think Travis is going to go over some of the technical aspects that make it a deep target and not necessarily a peripheral target. But if the peripheral targets do open up, there's going to be many, many applications. It is FDA cleared for VIM, thalamotomy, and essential tremor, and some tremor dominant Parkinson's disease in the adult world. But there's no FDA cleared indication in children, which is what the focus of this will be. So what are the possible uses of this device? Well, really, it's kind of endless for a functional neurosurgeon, but in my world, in the epilepsy world, I can think of three deep targets. Hypothalamic hamartoma is, of course, where I would go first and where you guys have gone first. But I think a lot needs to be done there as far as, which lesions to go after, how to strategize your targeting. There's a whole lot of work there. Periventricular nodular heterotopia is another big world. And one thing that people that epilepsy surgeons forget is that the mesial temporal lobe epilepsy, or the amygdalo-hippocampal complex, is really a deep target. So if we can get the focused ultrasound to be therapeutic in that range, a massive amount of epilepsy will open it up. Now, the oncology issue is, of course, self-evident. I think it just is going to require someone, probably a sacrificial assistant professorship somewhere, to devote their career to getting the children's oncology group protocol designed to get this done. Minimally invasive laser ablation, something I put my career on, has been talking about this for 10 years, but there's been no one out there that has decided to really make that COG protocol something everyone can get their brain around. So once that's done, I think the oncology indications here will open up, not just for the primary tumors, as I mentioned here, but also for METs. So the movement disorder world in pediatrics is not quite as tidy as in the adult world and its focused applications, but there are some pallidotomies that are done occasionally. Secondarily, there's the very, very rare VIM thalamotomy. But I think one area is very much interesting in the world of pediatrics is more of a cerebellar tremor, Holmes tremor, and action tremor world, for which the posterior subthalamic area has become an emerging target in pediatrics. Will thalamotomy there be effective? I think that would be an interesting study to look at here. And of course, in a world that I'm now diving headfirst into in drug and gene delivery, opening up the blood-brain barrier is going to be an important piece of this tool. I know my oncologists are very interested in the notion, but as I dive into gene therapy and gene delivery in pediatrics, we realize we can only, on a great day, get 10, 20% of the genes we need in the brain. If we can open up the blood-brain barrier and widen the gene delivery with this tool, it will be an immense task to accomplish. This minimally invasive epilepsy surgeon, of course, is focusing on hypothalamic hamartoma, and its applications here would be not just the epilepsy cure, but the palliation of epileptic encephalopathy, which is a unique indication in pediatrics. Maybe there's a role for rage attacks here. The physiology of that has to be worked out, but I do see that the Miami group has focused one of their treatments on the obesity issue here, which I think is fascinating. So if we can do that, and with the rage attacks in HH, it would be huge. And of course, the complication avoidance is always a big deal here. The goals could be either surgical destruction on the small one or disconnection on the large one, or even the staged approach. And this is a huge armamentarium that is approached here, but they're all relatively morbid comparatively. So decreasing the morbidity here is going to be a very important step forward. So what can it do? It can decrease the corridor related morbidity to virtually zero. Should improve this safety profile, although a lot has to be taken into account there with the premature head. There may be non-thermal mechanisms here that are going to be at play and need to be studied. And is this an actual outpatient sort of approach in epilepsy surgery in peds? Other than VNS, we don't have one. So what are the challenges? Well, we got a dose in the immature cranium because we know every intervention that we do is better earlier. So we can't wait for the maturity of the skull. So we've got to work out the science here. The dosing of the fluid interfaces is going to be a big deal because as opposed to the isothermic thalamus, we're in a very complicated microthermodynamic world where ultrasound could have all sorts of interactions that we're going to need to know something about. Can it be accurate down to the millimeter? These things are right up against your mammillary bodies. Lesion size versus ablation volume is going to be a big deal. Are we back to the RF days in which radiofrequency ablation failed to take off in epilepsy surgery because we simply couldn't make the ablation volume big enough or practical enough? We're going to have to refine our disconnection strategies if that's the focus that we're going to go down. And my biggest worry here, and I need to sort this out once I get my hands on it, is just where is the highest error in this machine? It seems to be, since it's a top-down approach, the highest error is where you don't want to be inaccurate, and that is in the base of the brain where the mammillary bodies are, if you're focusing on the hypothalamic hamartomas. So there is one very interesting paper that has been I'm sure Travis is going to mention this, where they decided to do a disconnective strategy with the Japanese group here. And here they've done a DTI and focusing on one area. And this is the size of the ablation that they did, this tiny little ablation here. And this solved the gelastic epilepsy problem. I must say I'm skeptical that they got the one fiber that was connecting it. This is a very fascinating paper and the outcome, but much more needs to be studied here, because if this is the way to go, there are plenty of these that need to be done in this manner. But I think we need to sort out what our connection and disconnection strategies are going to be. And of course, every time I talk about any thermal ablation in the hypothalamus, I always give this cautionary tale of trusting a technology too early, too much. This is a complication I had early on in the laser ablation days, where the 1 millimeter drop off was believed. And, we got the other side and we caused a bilateral mammillary body injury that was published, causing a significant deficit. So be respectful of the new technology, but I think there's no need to be too timid here. I think there's plenty to do. So with that, I'd like to turn it over to Travis. Just as an aside, he's been a great advisor in our development of our HIFU program here, and hopefully we'll get off the ground in the fall. He has a stellar and bulletproof pedigree for someone who's approaching this. He's a Oxford brain scientist that went to medical school at Hopkins. He residencied at MGH, did fellowships at your esteemed center, and at Toronto at the Valhalla of functional neurosurgeons. So if there's anyone that has the training to push this tool into the pediatric functional realm, it is Travis. So I will turn it over to him now.
Thanks, Dan, for that kind introduction, and Toba and Dr. Niazi and Heather McRae for introducing me and welcoming me back to Miami. I came back here to give this talk for a couple of reasons. I miss this place a lot. I think this symposium is a direct extension of why Miami Children's Hospital, namely Variety Hospital, is such a great institution. A fellow named Dr. Altman in the 1960s started something called the Pediatric Board Reviews here, and the whole world came, and they sat here for 10 days, and they learned their pediatric board reviews, and then they went home, and it ended up bringing a lot of notoriety to this place. And what I realized about Miami Children's while I was here was that this is one of the greatest teaching institutions that I've ever had the pleasure of training in. So thank you, Heather, and thank you, Toba, for training me. Dan Curry is the greatest enemy non-combatant you could ever have the pleasure of knowing. And with enemy non-combatants like Dan, you don't need friends, because his reviews, at least the review I think I read, was just stellar and has helped us think about how to put these ideas together in ways that make sense for everybody. Dan worries about things that are theoretical, but he's practical enough to know where the trouble is. So Dan, I mean, you've really guided me in my thinking over the time that we've been putting these ideas together. So today I want to spend a little bit of time giving everybody a real practical feeling for what it means to do focused ultrasound, not just in kids, but there is a focus on kids for sure, because that's what we're really interested in. But to take some of the lessons that we learned in doing focused ultrasound in adults and applying those to the pediatric realm. Can everybody see my screen? Is it being shared?
We can see it.
All right.
It's not on the projection mode though.
Yes,
Okay.
go to on the bottom. There you go. That one.
Yeah, okay.
Now we can see it perfectly, doctor.
So focus ultrasound, adult lessons for kids. I didn't really mean to make that sound so racy, but we made mistakes as we went along. And the folks who made the best mistakes were the world's greatest experts, the stereotactic and functional neurosurgeons, because we depended upon our theoretical understanding of what was going on in the thalamus, and that led us astray. So we don't want to make those mistakes in kids. I want to talk about 3 theoretical concepts and 3 practical principles before we even talk about any data. I'll talk about all the on-label stuff that we learned in adults when we did the essential tremor trial, and then briefly touch on the rationale for pediatric focused ultrasound. And that has something very strongly to do with non-ionizing radiation. I'm only going to talk about 2 cases today. I'm going to talk about one home run, which is indeed an interesting case, and the most important case, which is the strikeout case. And that's really the one to pay attention to, because that lets you know what the machine might not be able to do, and you can help me think of ways around that. There are some directions that I have biases towards in pediatric applications for focused ultrasound that have to do with movement disorders. And Dan touched upon a number of those already in better detail than I'll describe. But I think that pediatric dystonia and bilateral pallidotomies is possible. So we won't have to implant these kids with these one girl that Toba and I did, she called it her baby for a couple of years because the battery was so big in her belly. And it is a disfiguring operation in children, DBS. So there may be ways ways around that. For those of you who are not aficionados, this is the Insightec 4000 device. It's the only FDA approved device. I'll say right up front, I didn't put up any disclosures because unlike Dan, I've had a problem developing certain disclosures. Not that I don't want them. It's just nobody's willing to pay me large amounts of money to talk or do research for them. But Insightec has been supportive in a number of ways that have been non-financial. They have a very excellent regulatory division. And we got through the FDA in 30 days on a pediatric brain tumor trial. That does speak to the facility with which the regulatory division at Insightec interfaces well with the FDA. So kudos to them there, though. But they are nonetheless a commercial company, and I've never taken a dime from them, but they've got a nice product. First designed in the Brigham and Women's Hospital and templated and made real in Israel at the Technion by some steely-eyed missile men. It consists mostly of a helmet, a computer, and what I call the water cooler here. This water cooler pumps water into the helmet, which acoustically couples the piezoelectric drivers, which are simply speakers, to the scalp. If you take the hood off this thing, it costs as much as a Ferrari. So actually, it costs more than a few Ferraris. You can see the back of it here. And what this is there's 1,000 piezoelectric drivers all aimed at one central spot right here in the middle, just like a gamma knife. And Insightec would have you believe that the thermal dose fall off is as sharp as this pin looking thing here. And indeed it is. This is a H&E section from one of Jeff Elias's papers that shows coagulated brain separated by roughly 100 to 50 microns from normal brain. And I'm here to tell you it is that sharp in this plane, in the axial plane. What's going on in the SI plane? I think Dan talked a lot about that. What happens in the far field down here? We've got some evidence that things do happen, and I'll touch on that in a minute. I want to touch on the concept of electrical focusing, because that's really critical for understanding how to use this device. You don't have to move this array around. You can use a computer to do it. And the guy who came up with this idea of the steerable phased array was a very interesting man named Frank Yoles, who died a couple of years ago. The way that focused ultrasound was done, beginning with Lars Lexell, by the way, Lexell decided that there wasn't enough computer control to control sound waves. So he moved on to radiation, which he thought was a lot easier to work with. And hence Gamma Knife was born. But he was one of the first. And then the Fry brothers in the United States here used parabolic arc reflectors, which had a fixed focal point. A really elegant way to do this, vibrating at ultrasonic frequencies. And they could heat up that little point. That works really well for the body system where you don't have a lot of bone to go through. And that is the basis of the current body system, which is available commercially. Frank Yoles predicted that to have enough energy to get through the skull, though, you would need a parabolic arc reflector that's about 10 meters across. So that made that a little bit impractical. And what he did was to use his engineering background to break this thing up physically and electrically into a whole bunch of little pieces. He put it in a dome, and then he ran wires in the back, and he could control the incident sound waves. This thing here does not take into consideration what's called deconstructive interference, where one of these signals will hit another one over here and cancel it out. But Frank's system did. He can make sure that all of those incident sound waves line up right here with constructive interference. But even more importantly, and the most important practical thing here, is you can steer this around just with a computer. I don't understand the physics of it or anything like that. But what I know is you don't want to move a brain when you need sub-millimeter accuracy or the phased array that's around it. You want to move that just electronically in non-solid state with just digital movements. And that's what we do when we do VIM thalamotomies. This stuff got us in trouble. This is a theoretical idea that came from cats in the 50s and 60s, and some pretty famous studies done by Rank and others like that showed that neurons stop firing at 42 degrees, and that is indeed true. Proteins start to denature at 43 degrees Celsius. There's a time dependency to thermocoagulation. So if you stick around there for a little while, you're going to eventually kill the tissue, but you won't kill it right away. This number is worth tucking into your brain, 54 degrees. That is indeed, at least in gray matter, 54 degrees is instantaneous coagulative necrosis. The tissue's dead. So if you hit 54 degrees, you're good. But you don't want to go too hot, because over 60 degrees, you get what's called inertial cavitation, which is what happens in submarines. The little bubbles at the base of the submarine tail, what's that thing that spins around in the back? Well, the reason this is so studied there is because it makes noise, and that noise was detectable, and physicists, for obvious reasons, studied that. That's boiling. So this actually happens within the brain as well. So you want to stay under 60 degrees to avoid the concept of inertial cavitation. And I'll show you where we got in trouble with that too once. This idea here below 50 degrees was in theory put forward during the essential tremor trial to suggest that we could map ventral caudalis, right? We could stimulate ventral caudalis at low energy and get thumb numbness, just like we do with DBS, and then go 4 millimeters anteriorly and zap it. That was a bad idea. That led to a lot of paresthesias. So whoever said to map, and I do know who it is, ventral caudalis, was wrong. And you don't do things like that based upon theoretical principles, especially when you start realizing you're having permanent paresthesias. 54 degrees, 60 degrees. Those are the key critical things to just keep in mind. There are some interesting things about the pediatric skull that are important from a real practical point of view. The pediatric skull gets to its adult size roughly at age 7 or 8. That may or may not be why that's the lower cutoff for DBS, I'm not sure, but that was the lower cutoff for our trial, was 8 years old. And that's because the incident angle changes. When you get above an angle of 25 degrees, the sound tends to bounce off the skull and back out into the world. So it's like looking in a pool. If you're above the incident angle, you can't see through it. And small skulls have high incident angles and do not transmit sound well. But that's not the end all be all. There's also a problem within the skull itself. It's called the diploic space, which is full of fat. And we had to figure out why certain people with fatty skulls didn't do so well. So we came up with this idea of it's not really important to remember this, but it's called the skull density ratio. And if you ever do focused ultrasound, that'll be the number you're keyed into all the time. The FDA cutoff is 0.4. It goes from 0, which is the skull density ratio of sort of styrofoam stuck in oil, to 1, which is a skull density of marble. I'm pretty happy when I see an SDR of 0.45 or above. I'm ecstatic when it's 0.6 or 0.65. I have noticed, though, on the super high density skulls that we tend to get a pinpoint lesion in VIM, and I got to move it around. So there's something that's beyond optimal, called a U curve. So somewhere around 0.6 for a skull density ratio is good. And as long as you're operating on humans that are adults, you don't got to worry about this incident angle stuff, but we're going to have to think about this as we get under age 8. Those are some nice practical principles, but this, if there's anything you want to remember at all from this talk, it would be this slide. And I think Dan Curry was talking a lot about this. This is currently the acoustic thermo envelope of the 650 kilohertz device that's FDA approved. And I think you can see why the functional neurosurgeons like that. There's STN right there. The pallidum is up here a little bit. The thalamus is just above this structure. And even the medial heads of the hippocampi work its way towards the edges of the 650 kilohertz device. When you drop the frequency to 220 kilohertz, you can reach more of the brain and still hit that magic 54 degrees. And this clearly in the 220 kilohertz device can reach out to the corpus callosum and out to the hippocampal head. So the epilepsy surgeons start to get interested in that. But the first trial that was proposed used the 650 kilohertz device. That was Vibor Krishna's trial at the University of Ohio State. And the current trial in the United States, which I'm not a part of, uses the 650 kilohertz device, I think, as well. So everybody out there thinking about buying the 220 kilohertz device and who have been encouraged to think about that by Insightec, give me a call. I don't think you're going to need that device. These are basically the same helmet with slightly different tuning, as it were. They're both Lamborghinis, but they're tuned in different ways. So you don't want to pay $2 million twice. There is a way to reach the entire neuroaxis and maybe even the spine. The spine guys here asked me that a bunch of times. Can you get to the spine? Nope, not really that interested in the spine, but I can tell you if we use something called histotrypsy, which is like lithotripsy, so ultrasound guided ultrasonic histotrypsy will allow you to get virtually anywhere in the neuroaxis, and it makes a lesion within microseconds rather than seconds. So we won't need the Lexel frame. We'll just have to worry about bleeding a little bit more, I think, than we have with thermal ablation. But the key take-home message is we're here stuck in the middle at the moment, and we're working our way out with physics. And eventually, we'll get all the way out to the cortical surface, I think, with no problem, and maybe even for vascular lesions. But this is where it all started. It wasn't my idea. It was Jeff Elias's idea. And it was a really good idea because treating essential tremor has an obvious endpoint. The tremor goes away right there on the table, right? And it was a beautiful outcome. Frank Yoles actually started with tumors, and that was a disaster because he had to figure out if it actually did anything. And all those guys doing tumors, they don't have a really hard endpoint to really watch right now. So I'm really proud of what Jeff Elias did and thought about and how he did those trials, because it was an absolute pleasure to work with him. And he asked me to be a part of that. And I learned a lot along the way. I didn't even know how to do a thalamotomy, even though I was from Toronto, right? I had to learn how to do this myself. In fact, when Toronto tried to teach me how to do it, I realized that I wasn't doing a very good job because I was trying to do 60 degrees for 60 seconds, just like Andres told me in the thalamus. And that was too much. And my first patient really got off the table pretty wobbly. So we all went through a learning curve, and that learning curve is now published. So all the stereotactic aficionados are out there saying that focused ultrasound isn't this or isn't that versus DBS. The key thing to look at there is the recent St. Jude's trial, where the best stereotactic functional neurosurgeons in the world helped St. Jude get their FDA approval for tremor. They showed an overall 67% rate of tremor reduction. I was really depressed when our paper came out in the New England Journal with barely a 50% tremor suppression. Here, look at that. So what I thought when I did DBS, it'd be 100%. I mean, that's what I thought. But very rarely do we get that. Look, we had some really bad things. I mean, we didn't get any help down here. This happens to be the folks who are from Seoul, South Korea. And that's where the aegis of the understanding, rather, of the skull density ratio came from. Zhangwu Chang worked that out. He didn't know why it wasn't working in his patients. They're relatively brachycephalic. Folks in Asia might just say we're relatively scaphocephalic, but the incident angle was smaller indeed in the Asian population. So they tended to strike out a little bit more, and that explained a lot of this stuff here. So Zhangwu Chang put that together. He established the concept of only operate above a skull density ratio of 0.4 and you're going to be fine. Remember, this was the first time through the forest here, these 76 patients. So when I operate on these patients, I tend to think I'm still at 100%. I know I'm not, but I can tell you that I've become as good a thalamotomy maker as I was a DBS installer. And you can say what you will about that, but my efficacy rate is the same. And I think that the durability of the thalamotomy is the same as for DBS. So all this stuff that's out there in the literature could be settled with a head-to-head that people says can't be done. And I'm here to tell you, yes, it can be. My patients, if I ask them to do DBS, will do DBS if I ask. If they want to do a thalamotomy, and they all do, they will. But I'm pretty sure that we could think about a randomized trial, but nobody believes that, although I do. And that's just because I do the most focused ultrasound folks in the world. So I don't believe some of the things that have been said even in the open literature, and I certainly don't believe some of the things that are being said at meetings. But I do believe the data that Jeff showed us. Look at that. If you didn't get energy here, you didn't get an effect. If you got energy, you got your tremor reduced, and it was relatively stable out through a year. Now we got 3 and 5 year follow-up data. A thalamotomy is a thalamotomy. If it's done well, it's durable. If you don't do it well, it's not durable. You got to go back and do it again. But that's the beauty of focused ultrasound. I've got a 6% strikeout rate where it comes back at the end of 6 weeks because I missed. But I take them back and I do it again. And I've got a 0% bleed rate and a 0% infection rate versus a 4% infection rate with DBS and a 0.5% risk of bleed asymptomatic with DBS. So in my mind, I don't know how we can go with something that's as effective as focused ultrasound with much safer safety margins compared to DBS. I don't understand the controversy, but I'd like to have somebody challenge me at the end. At any rate, this is really important. The New England Journal paper described what patients thought about and what neurologists thought about the outcome, not just in terms of tremor capture, but in terms of their lives. So all of this stuff got better if you got energy, right? But if you didn't, it didn't get better. So that was great, and it seemed to be durable out through a year. This is very important. Speaking got actually better with the thalamotomy, and we were all worried that we were going to cause dysarthria. And I'm here to tell you, you do get dysarthria. The fricatives are screwed up for about a week and a half to 2 weeks. I took the train to Topeka, Massachusetts General Hospital. Those things are hard to say for my patients. And when it happens on the table, I do get worried about it and I move laterally. But look, we didn't hurt language, at least the fricative language. And we're going through that all over again now with a bilateral trial. Everybody said there'd be a 20% rate of permanent dysarthria, and we just haven't seen it. So you can do a thalamotomy bilaterally. You can actually operate in the thalamus, unlike what Walter Dandy said. But when you do so, you can make mistakes. And these have been swept under the carpet, and it annoys me. It annoys Ron Alterman. And he put a really nice review, I think, that was a little harsh in the Red Journal, but it's true. We don't talk about the A&Es so much. And the reason we should is because we can learn something. We had a 40% rate of paresthesias and ataxia in that trial. So I don't know, if I sent 16 patients back to Mike Hayes or Alan Roper, who were my movement disorders neurologists, that had ataxia and paresthesias, they're not going to send me any more DBS cases. We did wait a year. This is at the 3-month mark. At the year mark, that dropped down to a 14% rate of paresthesia, but still a 9% rate of ataxia. And I'll tell you, those complications probably were mine. I was really going towards RF lesion heat, which isn't what you want to do when you do this. So we've gotten a lot better at that over the years, but this is the first data during the first 76 patients, and there's a solution to this. The main solution is to say that they happen and figure out why they happened. So if you got paresthesias, you were too posterior in ventral caudalis. And we knew we were too posterior because we were mapping in ventral caudalis, some of us at low energy. That was a bad idea because that predisposed ventral caudalis to a lesion when you moved up here and really blasted it. So what I do now is I don't start even in VIM. I start up in VOP and I work my way backwards to a classic target. And if I have a hint of paresthesia, I stop. So I don't look for paresthesias anymore. I try to avoid it. And that's a way that you can get your paresthesia rate down to roughly 15% off the table instead of 38%, and down to about a 4% rate of paresthesias in the tongue, not the hands, in the tongue. I think you can get it lower than that with a few other things. Dysarthria is not to be worried about. There's not going to be any permanent dysarthria from a thalamotomy done with focused ultrasound. I thought that this 4% rate of paresis was totally unforgivable. How could you make somebody weak? But I found out it's actually really easy to do. And I think it's probably a lot higher than that, because you spill energy over into the white matter tract really easily when you're out laterally. And in the folks who have larger ventricles, which is a lot of these people who are a little bit older, VIM gets a lot smaller. The white matter tracts pick up heat much easier than the gray matter tract. So you got to be a little bit careful. I think that 54 degrees necrosis that we talked about is probably significantly lower in the internal capsules or in the white matter tracts. But this is the part that's really the most interesting. This rate of ataxia, where it come from? What are we hitting? I've had unilateral arm ataxia, arm, not leg, okay? I'm not sure exactly what we're hitting, but I think it's going too deep. I think we're underneath the thalamus. We're hitting the rubral spinal tract, I think. So the solution to all of this, one, is to talk about it and to stay 1 millimeter or 2 millimeters above and in front of the classic stereotactic target. So again, the guys that made the mistakes were the theoreticians who were highly trained, not paying attention to their patients. So the whole field has learned, and Nir Lipsman has written the best on how to do this and how to avoid these complications. I just learned by doing it, by making mistakes myself. But if you've done enough, you can go and not make these complications and have an understanding of how the tool works, because you know the classic phrase. So we tried to take some of those lessons and apply them when I came to Miami Children's to treat pediatric brain tumors and epilepsy. And the theoretical idea for this was that there's no statistically safe dose of ionizing radiation. We know this, I think, pretty well from the studies that were done after the war in Japan. At least in children, there's probably not a safe dose. And that's why we do the fast scans and all the ultrasound stuff to image those kids up. We think it may be a safer alternative to or adjuvant to conventional surgery. So if there's that little bit of medulloblastoma in the corner there that you couldn't get to, is it worth opening it all up and going back in there, or could you take that out with focused ultrasound? I'll tell you a couple cases in a minute where we treated with lit and then we weren't successful and we went back and touched it up with focused ultrasound. And that's indeed how we started. Could we ever replace SRS with focused ultrasound? I think we can. Certainly we're not going to be able to replace all of ionizing radiation with focused ultrasound. But if we think about focused ultrasound with blood-brain barrier delivery of chemotherapeutic agents, like Dan talked about, maybe we can push ionizing radiation back to the dark ages where it probably belongs. So we started this trial called the Feasibility Safety Study using the Exablate 4000 system in the management of benign centrally located intracranial tumors. I read that thing at a meeting. Actually, Henry Brem read it, and he told me my time was almost up. The FDA helped us with this title. They helped us put together the study. They lengthened the study by a couple of years in the follow-up. What I think they did was really good. And as I said, we got through that trial in 30 days. So these are not impossible things to put together. But Dan Curry may be right that if we go through the COG protocol route, that this could present a challenge. But I think it's one that we could all take on as a unified team and not worry about the regulatory stuff so much. Dr. Niazi, how much time do I have? Should I just wrap it up?
You have about 18 more minutes or so keep going.
Well, let me go through the structure of the trial because it's important and it gives you a way to think about how further trials may be structured. the FDA wanted us to do progressively younger cohorts. So the upper bound was set at 22 because of some of the bylaws initially within the hospital. And we were going to go down to 8 years of age based upon some work that Jim Drake's lab had done with focused ultrasound and Adam Waspy at sick kids. They realized that the acoustic window closes at around that time, but interestingly enough, reopens again when the anterior fontanelle opens. So, Adam and Dr. Drake's group have really done a whole bunch of very interesting things on using focused ultrasound to break down clots in the pediatric brain for hemorrhage. But the FDA made us be safe. They made us do a cohort of 3 patients between 18 and 22, and that really limited us. We had a hard time finding those patients because of that narrow age gap. So it took us a little time to get off the ground. At least that was our excuse for a while. And then it did open up to 12. And I think we've done enough now where we're almost open down to 8. So we need to recruit 10 patients between the ages of 22 and 8. And we've done 6. Since 2017. So this trial's going a little slow, everybody. And folks like Dan are coming on board to help us, but so are some other groups that could help us. The adult groups could be doing some more peds. And I think what we need to do with this trial is rather quickly turn it into a pivotal trial. I think our safety stuff is already there. We haven't made very many errors. In fact, I think we've made much fewer errors than we made on the thalamotomy trial. So it's time to move on. I think we could also turn this easily into an epilepsy trial, and I'll show you what I mean in a minute. Ideally for this trial, the patient should be asymptomatic and show some growth velocity. The key is you want to be able to treat something that is WHO1 looking, that you would consider doing surgery on. And I know that that may be a little rare, and that's probably why we've had a little trouble recruiting. But this little thing is key, and I put this in the trial. Prior craniotomy is okay. This was the first focused ultrasound trial where the skull could be cracked. And that really helped us out a lot because the first cases we did were rescue cases. So if you've got a pesky remnant somewhere that you don't want to go after, and it falls somewhere within that treatment envelope, which incidentally does include the superior part of the cerebellum, let us know about it. The bleed risks, or sorry, the exclusion risks are just broken into certain types of risk: bleeding risks, hydrocephalus risks, and oncological risks. I don't think I'll say a lot about those. Those are all in that FDA clinicaltrials.gov identifier. This is our supposed home run case, and I think it really was. It was a fun case to do and think about. 22-year-old girl with gelastic seizures that did not generalize on many anti-epileptic medications. Also with oppositional defiant disorder, as Dan mentioned, they have rage attacks, and she was maintained on an antipsychotic medication. We attempted a laser interstitial thermal therapy to cut this wide base off. I think we did a really great job because look, there's the laser cavity. And look how far out laterally we got, almost to the optic tract, but she was not rendered seizure free. We thought that this little isthmus of tissue might be a problem. We weren't sure. We talked with her a lot about it. We considered a repeat laser gamma knife. And she was one of the first volunteers for focused ultrasound. So what we did was we targeted that isthmus. Actually, we were a little bit less conservative than that. We tried to cut the rest of the hamartoma off of the base of the brain. For the aficionados out there, this is a beautifully shaped spot. It's round. It's centered where you want it. It's got sub-millimeter accuracy. We hit an average peak temperature of 59 degrees in this run, but look, wow, we got to 62 degrees there. So we did run the risk of some inertial cavitation, and I'll show you where we got that in a minute. But what we did was to start behind the thing and work our way anteriorly here up to the cavity and cut it off. It wasn't a short case. I mean, it took us I think 17 hours to do this case. But on the other hand, she went home the day after surgery. And these are some of the shots just lined up in a coronal section. And we started out laterally in tissue that we knew was good, in that beautiful gray matter away from the ventricles. And then we worked our way medially. And as we did that, as we worked our way medially, we also worked our way anteriorly to do a true disconnection surgery. And I've got a video here that helps you actually, I think, experience what we actually see during the procedure. Of course, the whole patient's there in the intellect cell frame, but we stripped all that away just to leave the skull and the phased array. So there's all 1,000 drivers. Half of them are cut off there, but there's half the skull. And here they're all aimed at one spot centrally. Notice how there is a lot of hay around there. I mean, these aren't super sharp, but nonetheless, the thermographic phased array map is right there, and it's sharp, and we can see it from run to run, and even during the run. Here's where we got our acoustic cavitation. Look at that. That's a hurricane. That's a Miami hurricane right in the middle of the brain, about 4 times bigger than a standard thalamotomy. And we didn't expect that. I think it was the money shot, but we wonder, and Dan wonders, how close did we get to trouble? I don't think we were actually all that close in retrospect. I think that actually helped us. And I think we might be able to use inertial cavitation to help us operate. But as of now, we're considering that stuff uncontrollable, and we reported that as an adverse event. But we got this case done, and she states seizure-free now for almost over 4 years. And she's off of her medications and off of her reserpidone. So very quietly, Dan realized we've done some psychosurgery in children with this kind of epilepsy. So she did have one cluster where she came off of her anti-epileptic medications rapidly, but I think that anyone coming off of those number of medications rapidly is going to have some trouble. So we're working on getting this case and a few others like it published, and we have a really fascinating one that I'm not going to show you, where we had a pedunculated hamartoma, and we cut that off, and the girl lost a lot of weight effortlessly. This is the most important case that I want to show you, though, because it's a strikeout. It's a failure. 19-year-old boy with tuberous sclerosis, subependymal giant cell astrocytoma with calcium flecks in it. Not a ton. It's not egg-shelled, but we worried about him. And we took him because he was on everolimus and he wanted to come off it. Can everybody see that? Or am I projecting okay? Okay, good. We were worried a little bit, I guess, about hydrocephalus, but he obviously didn't have any. But he was taking his junior year in Germany. He was at a school in California, and together with the treating group in California, we decided to take this fairly cognitively normal child with tuberous sclerosis to the OR to see if we could shrink that thing down and get him off of the everolimus. At least it won't be needed for that intracranial tumor right there. Now, everolimus treats a lot of things that aren't just in the brain, all the other manifestations in the brain. So we were a little bit hesitant about that as an indication, but that's what we did. Anyway, we struck out. Notice how that spot shape is no longer round. It looks more like a kidney bean. And it's right there. It's right there. It's right there. We managed only to take out about this much of this tumor, and it was near the ventricles, and it was distorted. And we saw too often acoustic cavitation here. This is acoustic splatter around. This is the carrier frequency at 650 kilohertz, which is sharp. Sometimes you see a nice harmonic there, but I kept seeing splatter. I got worried about it, especially as we neared that calcium fleck. and I stopped. And that's treatment failure. But that's a really, really important treatment failure. That defined what we didn't think we could be able to do with this device, and that's treat calcium-laden tumors. Although it was also pointed out to us that we were close to the ventricle, so we may have been at a fluid border rather than at a piece of calcium. Right now with the technology, you can't tell where the acoustic cavitation is coming from. Soon that will change, and we may try to operate near calcium again, but I think it was the calcium and not the ventricle, because on those other cases, we operated right up to 0.5 millimeters from the ventricular wall and didn't see anything like that. So these are the take-home messages I want to leave you with. Focused ultrasound is certainly capable of treating subcortical epilepsy unless the hippocampus is cortical, which it is. So I think we can take out the subcortical. And those cases have been attempted successfully now, unpublished in Japan. Focused ultrasound yields a highly conformal instantaneous lesion. Instantaneous in the sense that you can see it form. It takes you all day to do it because the thing is clunky, but it is a conformal way of doing thermal ablation, unlike an RF lesion, even unlike a laser. Even though we can move it, you can't steer it around like you can focused ultrasound. And that's pretty important when you're operating in the thalamus. Cavitation, I believe, is likely near calcium. I don't think it's actually all that likely near brain fluid interfaces, but that remains to be seen. And we could test that out on tumors that have fluid pockets. Someday we will. Important message for children, no radiation. There's been no hemorrhage in 5,000 cases that have been done in the thalamus. And I've done 500 of those, and there hasn't been a hemorrhage, and we haven't had an infection. Those two safety points really just don't get talked about enough. That's pretty important. You know, we're not doing harm with this tool, right? We have the possibility to do harm with inertial cavitation, but then again, there's that theoretical mind raising its head with it no practical world evidence for it being trouble. In fact, I think where we saw it, we actually saw it as help. So I don't want to be a Pollyanna. What I really want to say is you can't trust the theory. You just got to get in there and do it. And that's why we need this regulatory approval for peds. That's why we need to get done with this trial now. I'm glad Dan's here helping us out. He's always been there. He knows the direction we're going to go. And if you guys have some cases you want to send Toba or me, give Toba a call, and then she can call me on this number, Toba. And then what we really want to do is do an international pivotal trial with a minimum of 5 sites to get world approval for peds brain tumors, at least WHO 1, and then they'll let us do WHO 2. The DIPG stuff is getting off the ground right now, with Toronto leading the way as they always do. I think we should do palletotomies bilaterally staged for primary dystonia. At least we could do a unilateral, see how that goes. And then if we're brave, we could do a bilateral. And then if we're really brave, we can apply for the HDE from the FDA, just like they did for DBS, to treat those rare conditions. I think epilepsy is the high ground. Miami Children's was always right to think about that and focus on it. There's so much to be done, from knocking out the epileptic foci temporarily. I saw a really interesting study where they did BBB opening with propofol, and the propofol stuck around for a couple days. That was fascinating. You had a block, and then you could go back in there and take it out. All kinds of things like that, I think, could be done in the realm of epilepsy and change really the way we do epilepsy surgery, because this stuff is really easy to do. It can be done anywhere, virtually, by anybody. I think I've proven that. Being in the middle of a cornfield in Nebraska, right? They all come and we do that. So this technology is sophisticated, but it's so sophisticated it's easy to use. So it should change epilepsy surgery. I have my doubts about neuro-onc, actually. I have my doubts about BBB, but I'm a skeptic. And again, I had huge doubts about thalamotomy for essential tremor too when I started this. So I'm prepared to be a skeptic, and then I'm prepared to drink the Kool-Aid after I try it and see it. And some people may say I have, but I think everybody who knows me knows that it is hard to convince me that something is a good thing unless I see it for myself. So if anyone wants to come do cases with me, they're always welcome to come to Nebraska City and do cases. I think that's really all I had to tell you, everyone. These are just some examples of some other things that Dan's already mentioned that you can think about. More hypothalamic hamartomas, uncalcified SEGAs, the perinodular ventricular heterotopias, et cetera, as a way to at least get through the trial at Miami Children's. Thanks very much for your time, everyone.
That was great and gave, I think, everyone a lot to think about of potential options for use of this treatment and where the field may go in the future with this. We're really hoping that a lot of you on here will type in your questions, a great opportunity to have discussion and answer questions. And while that's getting started, I'll ask a question. I think you talked a lot about how this technique can be used for ablation. And there's also a lot of discussion about blood-brain barrier disruption potentially for tumor. Could you talk a little bit about, for those who are not as familiar with the technique, of how you can use ultrasound to do such different things and the differences in the technique between ablation versus opening the blood-brain barrier without causing damage and allowing it to reclose after delivery of drug?
I can talk about what I know and what I've read, because I don't have any experience with BBB opening. Todd Mainprize led the way in Toronto. Really a pioneering man. Did this, 10 years ago, and was able to show that I forgot the doxorubicin maybe was boosted by 400% within the penumbra of the blood-brain barrier opening versus normal brain tissue. So Todd did focus ultrasound, went and operated, biopsied inside and outside, and was able to show that there's boost. That's great with that drug that's kind of not crossing the blood-brain barrier too well. But what about temozolomide? Why would you need focused ultrasound for that? People are doing it. Doesn't make any sense to me, but there's still a boost of 1 or 2%. I think there's probably a lot of drugs out there that don't get across the blood-brain barrier that may not have been of interest to folks who are thinking oncologically because they just don't get across. Frank Yoles himself wanted to use the antibody against the breast tissue for Mets. He thought you could open the blood-brain barrier and let antibodies get across a little bit better and not have to operate on those things. So I don't know how it's going to work out. I'd be surprised if there's a home run in any of that blood-brain barrier stuff, but it's not a surprise that I really want to tackle. And that's for this very reason. You got to do Kaplan-Meier curves and sit around and wait and then do all the statistics. And I'm just too impatient for that. I want to see that epileptic focus go away, and I want to see the tremor stop. So, I'm not as patient as most people. So the patient folks are going to be doing oncological things. And Graham Woodworth in Maryland is a very patient person. And I think it's designed probably a really elegant protocol for blood-brain barrier opening in the context of adult glioma. Of course, where we're all very, very interested in this in the peds world is DIPG, where there's nothing to do. Can we get the right drugs to the brainstem with blood-brain barrier opening? And as you know, you've been thinking about this a long time. Maybe we can improve the survival doing it this way. But the short answer to this whole thing is I don't know. I think it's fascinating, but I don't know where to go with it, I guess is the answer.
And but before we transition to other questions, I'll segue that. You mentioned DIPG. Our next Miami Zoomposium is actually going to be focused on DIPG with Michelle Manji and Amanda Saratzis speaking. I'll share my screen to just put up the flyer. That'll be on July 12th. Some great work there on from Michelle Manji on sort of understanding DIPG and the biology, as well as some new potential therapeutic strategies. And then Amanda Saratzis is looking at liquid biopsy for DIPG. So that'll be great for our next session while we're talking about DIPG.
So Travis, thank you for giving us this this talk. If you, so I know you touched upon this a bit. So right now, this the clinical trial that's going on here, it does not require biopsy proven, correct? If you could just run through that, just so that we can get a handle on the types of patients that would potentially be candidates for this group, and then the other question, so I'll let you answer that question, then I have a couple of more questions for you.
Okay. Well, I say they don't have to be biopsied, but it turns out like most of our patients were. So I think the remnant cases are ideal where you've got some tissue. If you've got a SEGA, we could try it again, or of course a Hamartoma case, but Dan does all those. So he'll get a machine, help us out. But no, they don't have to be biopsied up front. And could we make a mistake there? I suppose. But I also excluded all the WHO things that bleed, like a choroid plexus papilloma or something that I thought would bleed. I don't think we should have limited that to WHO stuff at all, but that's just what the FDA wanted us to do. But you shouldn't be afraid of that because you don't have to do the biopsy. They were just trying to make us be as careful as possible. So I think when we go to do the pivotal, we should just open that up to pediatric brain tumors, period, and throw out all the pathological grading that has to be done after surgery. I didn't think it made any sense to put WHO into the title, but that's what they wanted because we didn't require biopsy. We didn't want to require biopsy. Liquid biopsy may be the way around this. I don't know very much about it. It sounds fascinating to me, but should we be biopsying all these first? Probably, honestly, yeah.
Okay,
yeah, I do
that's
think
that's a good question of how do you know, unless it's obviously a SEGA or a remnant, how do you know it's definitively a WHO grade 1? And then can you just touch base and let us know about kind of what's expected of the patients in terms of hair and that sort of thing for this procedure? Because that seems to be a big deal for a lot of these patients that are going through this. So if you could just go through that so that, if there is somebody that our audience members wants to send down to be considered, kind of what's expected, so it's not, a strikeout the minute they walk in. Does that make sense?
Well, there is some expectation setting, I suppose. Do we really need to shave the head? That's actually being debated at the moment. If you get enough degassed water in there, it probably will get rid of all the air from within the hair follicles or between the shafts. I'm tempted to try a few thalamotomies without a shave and just see what we get away with. That would be considered off-label, but I've seen one scalp burn in the 500 cases I've done, and that was underneath the silastic membrane in a little acne pit that must have held some degree of air, and it burned it a little bit. Not a second-degree burn or anything like that, but we've never seen anything on top of the scalp. So I think, again, that's all theoretical nonsense, and this cooling it to 54 degrees Fahrenheit, that just freezes the patient out. I've stopped doing that. I don't understand why we're cooling the skin when it's the skull heating up. And you know how vascular the skull is. So that doesn't make sense to me. But it is true, you not only have to have a clipper shave, Insightec wants you to do a full razor shave, and I do that. It's interesting enough, it's been the women that have been the most okay with that because they want to try a new hairstyle, a new hair color. They're more inventive. They wear their silk scarves. It's been the men who have tended to shy away from that because they lose some of their sense of, I think, manliness when they're, I don't know. It's Delilah and Samson maybe sort of thing, but there's some psychology around that. I think if you spend the time talking to these kids, you know, we could probably talk them into anything as we usually do. So I don't think the shave is necessarily an issue. And in a young child, I think I'd consider doing it if I could get away with it under the protocol without shaving them. But we could discuss that with the FDA. Yeah,
Okay.
but shouldn't be I hope it's not a showstopper in any one great case.
Yeah. Well, I really appreciate you coming and joining us today. This has really been an excellent discussion, excellent talk, Dr. Curry, Dr. Tierney. We appreciate it. And, you know, I look forward to seeing where we are 10 years from now with this modality, not only with epilepsy, but looking forward to the more malignant pathologies that we don't have options for, and we're putting these kids through surgeries. So it's an exciting time, and I'm looking forward to seeing where we go from here. I want to thank everybody for joining, especially the two of you, and we look forward to seeing you guys next month for our DIPG discussion. So thanks again, everybody.
Thank you, everyone, for joining, and we hope we'll see you on July 12th for some additional great speakers. Have a wonderful day.